Getting started. So here's my latest custom instruments, because like a professional golfer, I don't play off-the-shelf clubs, but in endoscopic surgery, it is so technically challenging that if you don't have custom instruments that articulate, it is really hard to get the job done, especially at the periphery. So here is the latest upgoing curette, so I can scrape and turn. The downgoing curette, it's like a pusher. The snaggle tooth, it's the ball tip probe that articulates, so I can pull on things. And then another articulating curette that I can easily turn and pull. If it was up to me, I'd have 10 different custom instruments, but I'm happy with 4 right now. We're getting started. First order of business is identifying the perfect entry point. So that's my first estimate. My second way to confirm it is to anesthetize the surgical tract with this needle before I make the incision. And if I'm off a little bit, I can make an adjustment of the incision. This is when you know you have a Formula One team. I barely talk. They just know what I'm going to do. Love this. I love anesthetizing everything before I make the incision, because I believe in the gate theory of pain. So even though you're asleep, there's some kind of magical force that knows. I'm going to use the spaghetti noodle dilator to very carefully and gingerly drive my way down to the surgical target site. Shot. Shot. Oh yes, I'm liking this. Oh wait, let me stick out my pinky. Use my delicate Asian fingers. Shot. Oh, I'm gingerly making my way down, looking at imaging, feeling everything like Helen Keller, and listening for neuromonitoring. And then also watching for your butt to jump. All quiet. Oh, whatever. That was our neuromonitoring physician telling me I'm in the spine. Shot. Okay, I've docked the spaghetti noodle dilator on the back of the disc at the working triangle, stuck in this really skinny little needle. Shot and save. And now I'm injecting the dye. Oh, you can already see the leak right there. Look at that cute little line, like. Can you save that? Yeah. Shot and save. You can really see that. All your negativity is just making me stronger. This is the next, over the spaghetti noodle dilator is this straw that's slightly bigger. So I'm making the opening bigger and bigger and bigger by dilating it open rather than ripping it open. I'm going to skip that reamer. And all the way down, I'm just feeling for everything. That's the fascia. Shot. That's the supraarticular process. Like taking off or putting on a tight ring. Gentle twisting. Shot, that's the disc. Yep. I can see how you can read Braille with your fingertips. It's amazing how much tactile feedback you can have. Okay, here's the initial look. Sure looks hyperemic in there, like there's lots of inflammation, but you can see the blue dye right there. The annular tear and disc bulge is posterolateral, so it's right where I went in. That blue is pathologic, probably. And I'm going to very carefully clear it out so I can see everything and make sure there's not a nerve in here. So a normal disc should be white like that, but it should not have an empty tension like that. It should be firm like a hockey puck. The exiting nerve root is way up there. Look away. I don't even want to look at it. It's sort of like a shy person. Does not like to be undressed and groped by a stranger. I get it. So I need to know it's not in my surgical corridor. So I try not to look at it unless I have to. And let's face it, sometimes I do. Okay, so now see that blue spot? I'm going to go medial and look for trapped pieces of nucleus within the dense white annulus. Release everything and start a new healing reaction. And with that, we're praying that he gets better. This is the new salt and pepper. Oh my God, this is so much better without the little clicking thing. Okay, so here's the Viagra ball tip feeler. It's curved. It's designed for maximum tactile feedback and pleasure. And right here, it's just stuck. And that's a sign of inflammation. We call it epidural fibrosis. And that is really irritating to a nerve. If you've ever had tape on your neck and you turn your neck and the tape pulls on your neck skin, you tell me how long you can tolerate that. Now imagine it's on your nerve. And every time you bend your hip and stretch your leg out, the nerve tries to slide and it gets stuck. It doesn't require a degree from Harvard Medical School to figure out that's not good. Thank you, Kendra. Kendra's my new filmmaker, because she's got an eye for style and coolness. She's also my fashion consultant. Sorry, getting back to the task at hand.
Back to the surgery.
Yeah, look at that fissure right there. You see that? That shouldn't be there. That's what I call caca-poo-poo. And my hypothesis is that the nucleus trapped inside there will incite a chronic inflammatory reaction, because in poor rabbits, if you take a rabbit's nucleus and put it onto the nerve of its twin brother, I know it's cruel, I don't think you can do that nowadays, and do histology, the nerve is just surrounded by a storm of inflammation. So the body does not like the nucleus, which is supposed to be encased in the annulus, but when there's a tear, it can cause inflammation as it leaks out. It also stretches the mechanoreceptors that line the outside of the annulus and activate those too. So it's a combination of chemical and mechanical irritation. And the body responds to all that kind of stuff like it's injured and initiates a healing response, and all healing responses go through the inflammatory process, right? Cannot have a healing process without inflammation. And normally the inflammation turns on and turns off. But every once in a while, it will not turn off and becomes chronic. That happens in the elbow, your plantar fascia, your greater troch, your PSIS right next to your SI joint, your medial elbow called golfer's elbow, your shoulder over the rotator cuff. And anyone that's had any of those disorders knows firsthand, A, how painful it is, and B, how long it lasts. Months, sometimes years. And part of the surgery, besides removing the offending agent, is initiating a healing response in a new environment and hoping that the new healing response will go down the correct pathway of turning on, then turning off inflammation. And that's the basis of this treatment. And that's the basis of why most annular tears are asymptomatic, because most annular tears heal and the inflammatory process turns off, but every once in a while that annulus does not allow the inflammatory process to subside, and it becomes like a tennis elbow, which I can tell you firsthand is really, really painful. Laser now. Sci-fi home laser. Look at how well this works. Anybody that sees me use it, they all go like this, oh, I see why Choll uses it, I want it. And then they find out how much it costs, they're like, oh, okay, can't afford it. But more people use this surgery, do this surgery without the laser than that do. But the master, the Jedi master of this surgery in Arizona, Tony Young, one of my mentors and heroes, he developed this laser specifically for this surgery. And no, but he is my endoscopic Jedi master, and Luke Skywalker. This is what an annular fissure looks like intraoperatively. That white stuff, that's the annulus. Annulus, and look at this right here. Look at that little light blue stuff. The dark blue stuff is probably nucleus, but look how it goes up to the back. That is such a good picture. That's what you get with underwater surgery. You can never see that in open surgery because this whole area fills up with blood and gets stained red. But with underwater surgery, you wash that blood product away. And I think part of the advantage of endoscopic surgery and why patients develop very little scar tissue afterwards is that you're constantly irrigating blood products away, and blood is very inflammatory. All right, I'm using the snaggletooth. This is also a new custom instrument. And so one of those things, like, once you've tasted honey, you cannot go back to sugar. Because now, if I don't have the snaggletooth, I'd be like, how am I gonna do the surgery? The same way you did it for the last 20 years, Dr. Kim. It's like, nope, I can't do it anymore. You showed me honey, now I can't go back to sugar. This thing is so awesome. It's just got this little hook thing that bumps into the scope. It's so annoying, but that's an easy fix. This is the articulating curette. It's on a new handle. Same thing. This is honey right here. I can't do the surgery without this instrument. I defy anybody to try to get this disc from underneath like this without an articulating instrument. I double dare ya. The way you do it is you detach the cannula and you drive the scope down and push down on it and reach the angle by angulating the instrument. That's good once you're like a master at it, but imagine learning how to control the cannula, the scope, moving the scope, getting confused as to where you are, and then like trying to do this without injuring the nerve right next to it. That's the definition of a terrible learning curve. It's like learning how to play golf starting with blades instead of cavity back irons. You're gonna suck way longer. It's that simple. Oh, I like you long time. I'm really happy that we're finding some pathologic tissue. My favorite. I love not having to talk or anything during surgery because everyone knows exactly what I'm going to do next, and we have all black belts in the room. 6th degree black belt to my right, 4th degree black belt to my left. The only white belt is Brad, but he should be grandfathered in because we worked together like 15, 20 years ago, and then he came back. So I think let's just officially make it real. He's going to just jump up to a blue belt right away, which is the fastest blue belt ever. Even taking into account the fact that we worked together 15 years ago, because it wasn't even that much. Not like it is today. And Brad reminds me to blink so my eyes don't get dry and burning. And he's really good at it. He's like, Dr. Kim, forgot to blink.
That's how I got my blue belt.
Yep. You can't get your black belt for a year, so don't feel bad. Okay, I'm done medially. I'm just going to clean this up, and then I'm going to look behind me now. But I can already tell behind me is probably pretty good because it's all white. We'll find out. Behind me is the exiting nerve root, so I have to be extra, extra, extra careful. And I save that for the last. So I minimize any perturbation of the DRG, the most sensitive structure in the spine in my mind. At least the most finicky and intolerant and prima donna-like of all the structures in the spine. Doesn't even like to be looked at. Here's the other reason why endoscopic surgery is so difficult. I've got the scope upside down, so everything is upside down and backwards on the screen. But imagine a day that I'm wearing virtual glasses and augmented reality. I'm looking down where I'm operating, and when the scope turns, the computer knows that I'm turning the scope, and it just keeps the image where it's supposed to be. And the image looks like an MRI on top of the fact that it looks like this up there on the screen. All together. And you can even switch back and forth between views. And you don't have to like change your brain into thinking, okay, I'm upside down and backwards. Because you'll be surprised that when I have other surgeons do this, they get so confused. It's like they're drunk because nothing makes sense as they move. You have to completely disconnect your brain with three-dimensional space. You have to like travel to another dimension, a two-dimensional world. Even though we developed and are hardwired to live in a three-dimensional world, you have to basically put all the pieces together. because even that image right there of the scope is a two-dimensional image, because the scope only has one eyeball. It's monoocular instead of binocular. You need two eyeballs separated to get 3D separation. So endoscopic surgery is a surgery in a two-dimensional universe. Okay, I'm feeling so good. I removed all the entrapped fragments. I'd released all the adhesions. That's the exiting nerve root. Look how red everything is. Now the exiting nerve root is one of those things that just does not even like to be looked at. I like that long time. All right. That went perfectly from a technical standpoint. Now we just need your body to cooperate and heal and get better. So after this, we're going to pray. We're going to burn some incense, and we're going to sacrifice some virgins, all in the name of your recovery. Okay, surgery's all done through that little poke hole. It went so well technically. And now for my favorite part, the world's most expensive Band-Aid, but it's also the cutest Band-Aid. And we're all praying for you and wishing you a speedy recovery. Right, guys? Yeah!